Hello, everyone. Welcome. Welcome to Kids Mental Health Pierce County January webinar. Happy New Year to folks. It is the first Kids Mental Health Pierce County webinar of the year. I'm so excited to have Claire Haligso and Rhoda join us. We may have an additional person from Seneca joining us. If you're not familiar, Kids Mental Health Pierce County is a community coalition of agencies and providers looking at streamlining and supporting behavioral health resources here in Pierce County. We are so excited to have this conversation today, looking at our youth crisis system here in Pierce County. Three of the priority actions for Kids Mental Health Pierce County are: one is improving access to our crisis system, access, wellness, and care coordination, and state and local capacity. So this is one of the components that Kids Mental Health Pierce County and our partners, you all here, and our community have looked at as ways that we could work together to support youth and families here in Pierce County. So I'm going to turn it over first to Claire, our behavioral health social worker at Mary Bridge Emergency Department, who's doing incredible work, working with young folks, looking at data and seeing how we can support them in the community. And then we will follow that with Rhoda and talking about the crisis system here in Pierce. So welcome and thank you for being here. Claire?
Hello, everybody. Just a moment as I share my screen and get my presentation pulled up. All right. Vanessa, can you see the presentation okay? I just want to make sure before I begin.
Yep, everything looks great.
Excellent. Okay, good afternoon, everybody. My name is Claire Haligso, and I'm the behavioral health social worker in the emergency department at Mary Bridge Children's Hospital. In my role, I manage and consult on our complex behavioral health patients, our long-stay patients, or patients who have been detained for involuntary treatment. Aside from patient care, another component of my role is more data and program focused, where I report on behavioral health trends we are seeing in the emergency department. I help to lead implementation of grants or quality improvement initiatives. And I also work very closely with the Kids Mental Health Pierce County team to represent the hospital side of things and collaborate on strategic efforts to improve systems of care for youth and families. So as Vanessa mentioned, today I will be, as part of the Youth Crisis System overview, I'll be presenting some findings from a large data review that I compiled last year that looks at current trends in our emergency department utilization for behavioral health crises, discussing what insights we have gleaned from those trends and what services are available to support youth in the community who are in crisis. So for our agenda today, I'll do a pretty broad overview of what our care continuum looks like, specifically in the crisis realm. We'll define youth crisis, and then we will understand what is available to youth in an emergency department when they present in crisis. I will then review the Mary Bridge ED crisis utilization data that was completed last year, identifying common themes and barriers as they have been reported by youth and families in their own experiences of accessing Mary Bridge Emergency Department while in crisis. And then I will hand it over to our lovely Rhoda Ramirez, who will be giving an overview of the Catholic Community Services side of things and what services they can offer to youth in crisis in our community. Okay, I wanted to start off with a brief refresher on what our behavioral health care continuum looks like in Pierce County. I got this image from the Kids Mental Health Pierce County team, so thank you, Vanessa. As you can see, behavioral health services fall on a spectrum, and in trends locally, statewide, and across the nation, we're seeing more and more youth entering the behavioral health system, specifically in this area through the acute intervention and crisis treatment services, where I put these purple arrows here. So for purposes of today's webinar, we're going to be focusing in on that area, the acute intervention and crisis treatment section of the care continuum, primarily looking at the emergency department, the crisis line, and mobile crisis services, how these entities work together to serve youth in crisis, and then also looking at data pertaining to emergency department utilization rates and some outcomes that we've been able to identify. Carillon Behavioral Health is the behavioral health administrative services organization in Pierce County, and their definition of behavioral health crisis is listed here, which I will read for everybody. A behavioral health crisis is any situation in which a person's behavior puts them at risk of hurting themselves or others and or prevents them from being able to care for themselves or function effectively in the community. And or a crisis is a disruption or breakdown in a person's or family's normal or usual pattern of functioning. A crisis cannot be resolved by a person's customary problem solving resources or skills, therefore requiring intervention at another level. I read that definition because I find it really important to emphasize that behavioral health crisis looks different for everyone because as humans, we all have our own unique experiences and unique skills and resources. And so when we consider how to intervene with youth in crisis, it's vital that we center each youth's unique experience to tailor an intervention that's effective for them, which leads me to my next point, which is that in Pierce County, Catholic Community Services, or CCS, is the primary organization who serves youth in crisis through their mobile outreach crisis teams, which can be accessed by calling the Pierce County Crisis Line listed here at the bottom of this slide. CCS does an amazing job of providing really tailored interventions to youth and families based on their unique needs to provide support through a crisis. And like Vanessa said, Rhoda, a clinical manager at CCS, is also here with us, and we'll dive deeper into CCS's services in the second portion of today's webinar. I wanted to take a minute to orient everyone to what an emergency department visit typically looks like for youth who come in for behavioral health concerns or who are in crisis. Before a youth is seen by a mental health professional for an evaluation, which in the emergency department is our social work team, youth must first check in, be triaged out front, and then receive medical clearance from a physician and also receive an assessment from their assigned nurse. After young people have been medically cleared, then our social workers can complete the mental health evaluations, which can take up to 2 hours, and they include a lot of different components, which are listed here on the slide. Once a young person has been evaluated, our social workers will engage in discharge planning with the youth and family based on the recommendations that came out of the evaluation process. The discharge pathway is usually one of two options. If a higher level of care is required due to the assessed risk, youth will be referred to an acute inpatient behavioral health unit for further intervention and stabilization. Those stays average 5 to 7 days. This referral would take place in situations where there is medical necessity for inpatient treatment. So there's a set of clinical criteria that have been met, and there is no less restrictive options available that can reduce the assessed risk in the community. Of note, there are very limited beds for inpatient treatment available in Washington, and even if a young person does meet medical necessity for inpatient treatment, that does not guarantee that they will be able to access a treatment bed. The most common pathway for youth, around 75% or over, depending on the month, is discharging back to the community after engaging in safety planning and being referred to the appropriate level of services. Okay, so let's jump into the data review. So first here, we can see the rates of emergency department utilization at Mary Bridge for mental health crisis since 2019. Between 2015 and 2018, we saw a 400% increase in emergency room visits for children with a behavioral or mental health concern. And since this increase, the rates have remained pretty steady over the past few years, July and August typically being our slower months. Across 2022, only around a quarter of youth seen each month on average required a referral to inpatient treatment. The rest of the youth seen could discharge back to the community after being evaluated. The most commonly reported chief complaint for youth seen at Mary Bridge were suicidal ideation, behavioral problem, and psychiatric problem. So as the complex care social worker in Mary Bridge, a component of my role, like I spoke to earlier, is serving as a liaison between Mary Bridge and community entities, including Kids Mental Health Pierce County, to communicate what we are seeing at the hospital and helping to provide some recommendations for strategic efforts to improve our system. And amid this growing pediatric mental health crisis, both across the country and in Pierce County, one of the priority actions, as Vanessa was speaking to, of Kids Mental Health Pierce County is to strengthen the community crisis response. And given the increase in the numbers of youth accessing medical emergency departments for behavioral health crises since 2018, we recognized a real need for some data around what trends exist in ED utilization so that we can frame our next steps. And so I took the lead on this data project, with the goals being to gain further insight into the current functioning of our crisis system for youth, present this data to key partners, including Carillon Behavioral Health and our crisis partners like CCS and Seneca, as well as the Kids Mental Health Pierce County Steering Committee, and then utilizing these findings to inform next steps in the community's strategic efforts. And so the purple arrow here indicates where we're currently at, which is as far as goals of this project, which is we are now taking what we learned from this review to translate it into actionable steps. How I compiled this data is I reviewed 200 charts of patients who sought care at Mary Bridge across the year 2022 for mental health concerns. 50 charts from each quarter of 2022 were randomly selected. My sampling criteria was patients who resided in Pierce County and patients who discharged back to the community. As I was speaking to earlier, on average, only around a quarter or 25% of patients seen in Mary Bridge require a higher level of care at an inpatient psychiatric facility. So in this data review, we really wanted to focus on the majority of patients coming through our doors, the other 75 or so percent, who come through the department and are lower to moderate acuity and end up discharging back to the community some hours later. In our first question, which was what events or settings most often precede a Mary Bridge ED visit, I found that most youth are coming to Mary Bridge ED from home after some form of familial conflict. Familial conflict was the most common trigger for youth crisis across the board, representing about half of the sample. Familial conflict most often occurred in the home environment. Almost 60% of youth were at home with their families before coming to Mary Bridge Emergency Department. The categories for the most common triggers of crisis, which were broken down into familial conflict, school stressors, peer issues or bullying, and then a recent life transition, those were inductively coded from the narratives in the charts. The most common story reported by youth and families involved some type of argument occurring at home, the argument escalating, and then that led to a young person engaging in a behavior or making a statement of concern that concerned the adults around them, and then ultimately led to a Mary Bridge visit. The most common adult response to a youth in crisis in the community amongst this sample was to bring the child straight to Mary Bridge Emergency Department, either the parents bringing them in themselves or a community partner recommending that the child be brought in and parents following that advice before trying another resource like the crisis line. This chart here illustrates all of the different entities that were interfacing with families prior to their visit and who recommended that the youth be brought to Mary Bridge ED. When we combine all of these entities aside from families, they actually significantly outnumber families in their number of referrals to Mary Bridge ED. Overall, families made the independent decision to seek care at Mary Bridge ED for a mental health concern only around 30% of the time, or in 60 out of the 200 cases, while families were referred to Mary Bridge by a professional in 64% of the cases from this sample. So as part of our mental health evaluations, we ask families, what are you hoping to get out of this visit? And this table here lays out what families reported to be seeking, stratified by who in the community referred them to the ED for crisis intervention. The most common interventions that were sought from a Mary Bridge ED visit, as reported by families, were risk assessment, respite, referrals, and then out-of-home placement. We saw school staff and families serving as the primary referents in cases where an assessment was sought out, and then in cases where families were seeking something other than an assessment, like respite, specialty referrals, or out-of-home placement, we saw law enforcement and EMS being the primary referents in those cases. So now we'll segue into looking at what was done for these families when they came to Mary Bridge, or what the most common interventions were. Looking at starting at the table on the right, the most common interventions provided to patients were safety planning, a referral to the community crisis outreach team, which is Catholic Community Services, and then also just providing psychoeducation around what's available in the behavioral health system and through an emergency department. This table on the left here shows us the number of youth who had history of utilizing community crisis services in the past, as well as the number of youth who ended up discharging with support from CCS, from their mobile outreach crisis team, during the hospital encounter that was being reviewed. Just over a third of young people from this sample discharged with crisis services through CCS. Our emergency department social workers make that referrals for families when they are at Mary Bridge before they go home, so that families can discharge with a supportive team of clinicians who can provide in-home support moving forward. This is a service that can also be accessed by calling the community crisis line. It certainly does not require a hospital visit to access, which means that many families are coming to Mary Bridge Emergency Department only to be referred to a service that they could have accessed in the community. Most cases from this sample were low enough acuity that they did not even require ongoing follow-up from the CCS crisis team, and ED social workers were able to create a comprehensive safety plan with the youth and the family during the emergency department visit, and then discharged them with some referrals in that safety plan. 80% of youth from this sample did not have any history with accessing community-based crisis services, which indicates to us that there's a need for building ongoing awareness of the crisis line and mobile outreach crisis teams that can be accessed in the community. Okay, overall, the majority of families, right around 61% from the sample, reported negative functional impacts associated with their Mary Bridge visit. Things like missing school, missing work, or missing outpatient appointments because of the time spent at the hospital. The second most common issue reported was that families just didn't get what they were looking for from their visit. As I discussed previously, a lot of families presented to Mary Bridge from this sample seeking things that fall outside of a medical emergency department scope, things like respite, out of home placement, specialty referrals, trialing a new medication, things like that. So it makes sense that over a third of families did not feel they got what they were looking for out of their visit. Amongst this sample, seeking a higher level of care at a hospital for mental health concerns did not appear to be any more effective in addressing the youth and families' needs. In fact, a significant number of families in this sample reported negative impacts from seeking a higher level of care when the interventions that they received at the hospital are also available through our community crisis services without having to spend over 10 hours on average in an emergency department. So we can consider the high number of referrals for low to moderate acuity youth to emergency departments as an area for improvement along our system of care. We want children and youth to be able to access the appropriate level of support in their own communities, avoiding the aspects of hospitalization that can often be traumatizing for youth, like being exposed to illness or violence in an emergency department, being restrained, riding in an ambulance or a law enforcement vehicle. They have all of their belongings removed, and most of the time, and most of all, having to retell their story to numerous hospital staff. Oftentimes, youth have to talk to people about the reason that they're there 7 times before they're able to see a social worker for an evaluation, where if they were to access something like the crisis line, most of the time they only have to tell their story once to the clinician in the community, and they can start receiving that comprehensive intervention much sooner. Okay. Here are some of the main action items that came out of this data review. We continue to identify the need for broader community education on crisis resources and services in Pierce County that are available, building awareness of the crisis line and the mobile outreach crisis services that are provided through our contracted providers. At Mary Bridge, we continue to build out our youth engagement services, or YES programs. These programs provide behavioral health navigation and brief clinical intervention to Pierce County youth who have been seen at a multi-care emergency department, regardless of insurance status, to target the vital need for follow-up care and linkage to services after a crisis encounter. Kids Mental Health Pierce County held a school-based mental health summit in October of 2023 with support from Mary Bridge, and that continued our efforts around strengthening collaboration between community entities for youth in crisis to really broaden that social safety net. And this data highlighted the need to have a youth-centered platform for discussing crisis system improvement. And so a youth crisis collaborative is currently being stood up that mirrors the existing crisis collaborative for the adult population, which is very exciting. And then also just continued partnership with our amazing colleagues at CCS and Seneca, who are equally invested in this work and who are right there with us in their efforts to build awareness, make positive change, and strengthen our system of care for youth in crisis. So with that, I will hand it over to the amazing Rhoda Ramirez, who will be providing an overview of the services that CCS offers the community. But if there are any questions about my portion of the webinar today, here is my email information. Please feel free to reach out to me, and then I will also try to put my email in the chat or have Vanessa do so in case anyone wants to reach out. All right, Rhoda, I will hand it over to you.
Thank you, Claire. If you want to add really quickly, we will have a little bit of time at the end that I want to give tips for some question and answers. There's question and answer box at the bottom. You could put some information into that, questions into that, statements into that, and we'll look at getting those answered at the end. I'm so excited and so grateful that Claire presented this information to the team. I also want to add for folks a little bit of context. So this data is from this past year when Catholic Community Services was our responding crisis team independently. And we are so excited to have Stephanie join us from Seneca Family of Agencies. This work in the community and advocating for multiple teams, knowing that we have a very big county, so many spaces, it goes deep all over, and a lot of folks needing to be served. So Kids Mental Health Pierce County and the various action and implementation teams talked about this for a long time with agencies in the community, looking at the level of need, knowing that we will benefit greatly from having multiple teams and options for support. So the data that Claire said when you heard crisis teams and crisis support, that was Catholic Community Services previously independently, and now we have a second team that has joined us, and they are started now here and expanded to serving Pierce County. So we're going to hear from Rhoda Ramirez, who many folks know well, and then we'll get to introduce and hear a little bit more from Stephanie, who might be newer to some folks, but we'll talk about some of the processes and some of their services and how to access them. So I will turn it over to Rhoda, and please go ahead and add any questions to the chat. And then after Rhoda, we'll hear from Stephanie.
Sure. If the slideshow is up, and if someone can help me with that, since I'm actually had some technical difficulties on my phone, but we are flexible, as Vanessa was saying. And if not, I can talk about what our program does offer as well. My name is Rhoda Ramirez. I'm from Family Behavior Health. Catholic Community Services. We have been serving the Pierce County area for a number of years now, and I'm so also happy for the partnership. And so most of my what I have is from Catholic Community Services and the programs that crisis program that we've been doing. And so I will kind of walk you through how we best serve the community when they are going into crisis in our process. I think Claire did a great job in outlining kind of what a crisis looks like from that end. And so if you can just go on to the next slide, that'd be great. Awesome. So we do have 3 programs that we offer at Family Behavioral Health Catholic Community Services. Um, and one is the longer program, which is WISE. That's can be, the average is 14 months, but that's for families that have multiple domains. Fast and stabilization is really a shorter program. It's up to 90 days. And we also offer stabilization to non-Medicaid families. For purpose of this, I'll be really focusing more on the crisis. So there may be some slides that will be kind of skipping or just I'll go by really quickly. All right. So with all our family behavioral health values, we work with the whole family, meaning the not only the youth, but also parents, any other extended family that they have. Our goal is always the safety in the home and in the community. We are strength-based, solution-based, try not really to blame or shame, but really try to come up with viable solutions. And we do collaborate with other agencies. A lot of times the youth that come into crisis, they might have their own mental health provider. They might have close connections with schools. Or be in the juvenile rehabilitation programs. And so we will reach out to them. We also utilize youth and peer supports, as well as parent supports. Um, and they are really parents and youth that kind of been in similar situations. And they also go out with at that initial crisis with the family. And which can be very helpful when a youth may be resistant or having just a difficult time, or a parent, like Claire related, some of the the parents really want respite, or they want out-of-home placement. And so our parent partners are able to come in and really talk about what that really looks like, how viable is that, and is that really helpful in the end. And so that's a resource that's very helpful. Okay, thank you. Okay, so when to call again, I think Claire went over some of this. When you're running safety planning, a brief mental health assessment, or even if you have questions about what next steps might be, if you need resources, that any high risk or dangerous behaviors, if there's self-harm, if there's extreme aggression, those are good times to always call. And again, I'll stress this a number of times. It's always, if the youth is not have a medical emergency, it's always best practice to call, whether they're at home, in the community, or in the school. Because if they don't have a medical emergency, they're going to the ER. And again, Claire stated they're saying their story over 7 times at least, and there's at least 8 to 10 hours that they'll be in the emergency room, sometimes shorter, I know, but the average when we get to actually talk to the youth at the hospital, they've been there at least 6 to 8 hours and they're exhausted, when we could have probably been there a lot sooner and met them in their home and school, or even out in the community. We've met youth out in the parking lots, in homeless encampments, and at the grocery store, wherever they're having a crisis. That's where we'll be. Speaking from Catholic Community Services, if we also try and I think it would do what's least restrictive. And so sometimes a family does believe the youth needs inpatient, and we can offer some other solutions. A lot of times the families is very exhausted. If you have a youth that's been suicidal for 3 days and the family's been up all night trying to protect that youth or keep that youth safe, they're just exhausted and need respite, or a break from that family. We can come in and we offer possibly overnight support, or bring in their natural supports to make sure that that family has that assistance that they need. We can, again, I think I went over that. And also I think the thing that, we have highly skilled clinicians, youth partners, parent partners, and just that sense of hope, where this is what I always think about. We're walking into a family's home and probably the worst moment of their life. I can't imagine what that's like, to have a youth that's suicidal, or one of my children. And we're having strangers come in and asking for help, and in a time that seems quite hopeless. And so that's what we try and do, is say, let them know that we can offer some substance, we can offer safety planning, we can offer supervision planning, we can offer referrals, and we also stay open until the entire crisis is over. So whether it's 3 days or 7 days, we make sure that the youth is stable before we do close, and we have daily contact. So offering that sense of hope that things can get to better. All right. Again, when you do make a referral, just very simple things. Name, of course, date of birth, address, where are we going, and the caregiver information. And hopefully the caregiver is there and present and knows, what's going on. That being, it's really difficult to safety plan if you don't have a caregiver. And in a crisis situation, the caregiver should really know what's going on. There have been times where maybe the youth is homeless, but we do safety plan whoever that guardian is, or even the homeless shelter. Some responsible adult we safety plan with. We will, and then also whatever that immediate situation is, so we can have an idea of who to send out there, as well as what the circumstances are, so we can be better prepared. Any historical information that you have, although that's not essential. And then any mental health provider or any other provider, are they involved probation, drug and alcohol treatment? That's always helpful. And again, we do ask that the caregiver be present, but it's not required. If the youth is at school and it might be an hour or two before the parent can get there, then we'll go out and start our assessment. And then the Pierce County Crisis Line is who you would call. I know that there's 988 is out there. However, at this time, all the kinks haven't been kind of ironed out. And so really, if you want an in-person response, that 800 number 576-7764 is the best number to call. We respond within an hour, and per our data, that's what historically we have been able to respond within that hour time frame. All right. So again, I think I'm trying to talk fast to get room for questions. And I know that Stephanie has some things to say too. But again, safety is always first. I think this is more of a repeat of kind of what I was saying. We do go to home residents. We work the family as well. So you can go ahead and skip this one. So youth crisis services, we do serve children under 18. In some circumstances, we might serve 19 to 20, depending if the youth is living as a child. So if they're 19 years old and they're still in school, and they live with their parents, sometimes we get calls from MOCT, the Adult Crisis Services, and they'll ask us, hey, would you respond to this? This youth they're over 18, but they still are living as a child. And so we will respond to them, not often, but sometimes. The youth are referred via the Pierce County line, Crisis Connections. That's where the 800 number goes to, and then they'll vet the calls, and then they'll call us and send us out there. We do provide a face-to-face evaluation, again, wherever that youth is. There is, I think, a 2 hour, I think it decreased to 1.5 hour per contract we need to be out there. But again, we're there in less than an hour per our data. Again, we partner with the families, the ER staff, the schools, We do provide a written safety plan every time we go out. We do make those referrals for more intensive services, which Claire did mention. That's something that the families are looking for. We sometimes, we do have psychiatric services. However, it's very rare that we use those services. And when we do, it's mostly for a consultation. We may also, like, again, provide lock boxes, door alarms, doorknobs, whatever the family may need to help lock up those items, risky items, like such as medication, sharp items, ropes, whatever would need to be put away for the youth. And then the interventions can run anywhere from, on the average, they run up to 72 hours. Sometimes we get there, things are okay, we safety plan, and the family is like, we're good, we don't need any other services. We do serve youth that come from out of county. If they're from out of county and they might be visiting, their grandparents, that happen a lot during the holidays. And they went into crisis, even if they're not from the county, we will serve them. And then also we will serve Pierce County youth that end up outside of the county as well, within driving distance. Like, we've been to Thurston County, King County, Kitsap County. We'll serve youth in those counties as well if they're Pierce County youth. All right, next slide. This is just a brief, warning signs of suicidal, if someone's having suicidal ideations, and just always to kind of refresh yourself. They doesn't always look like depression. That might be withdrawn, anger, maybe some additional sadness, any changes of behavior, loss of interest, a difference in their eating, sleeping, changes in relationships. Maybe they lost all their friends, or they have a whole different set of friends. And then paying attention to environmental things, like, are there recent deaths, does a friend group, do they have cutting behavior? Oftentimes what we find, if there's a critical incident among friend groups, then crisis comes up. There's more self-harm, suicidal ideations, more behaviors. And then again, suicidal can be romanticized. We do have youth that actually go into inpatient, they come out, and then they may self-harm or have suicidal ideations. And when we really talk and do an assessment, they say, well, I want to get back into the hospital because I met my boyfriend there, or I have friends there. So that's another thing to kind of look for, any substance use. And then just being, paying attention to what is said. We do get a lot of calls from friends who are concerned because they've heard their friends say that they wanted to harm themselves or they didn't want to live. And thankfully that they actually have reached out. And so we respond to that as well. All right. So next slide. Our stabilization really is, if a youth goes into crisis and needs a little bit more than just that short crisis intervention, for non-Medicaid families, we're able to stay open longer to make sure that those referrals are made and they're connected to community resources. And so they might be open up to 8 weeks, but it might be 2 weeks that they're reconnected. And so we don't necessarily have to be open for 8 weeks. We also have the FAST program, which is also a longer stabilization, and those are for Medicaid families, and they're up to 90 days. And again, some of the similar circumstances, they might be family conflict, some emotional behaviors, and they have a full team as well. They'll have a clinician, parent partners, maybe a clinical care coordinator. And those are kind of brief, intensive in-home services. Okay. And then our WISE services, I think, which most of you are probably familiar with. With our WISE services, we can serve youth up to 21 years old. And we get the referrals from community members, families, youth can self refer, and they again have a team. And these are intensive in-home services, and these are really for families that may have like issues within several life domains. Maybe there's historical trauma, poverty. Maybe they just moved from the area and they have little connections. So these are kind of longer interventions. So next slide. We also have a program, just to let you know, with the Tacoma Public School Districts, where we collaborate with some of the schools. I think there's about 12-ish schools that we work in currently, where if a school identifies some youth as having some issues or having, a little bit of problems, then that rises above what the school counselors can provide. Then we'll go out there and do an assessment, maybe some brief individual counseling, and then make referrals. Some other things that we have done well, let me go to this slide. Because the police and fire have so limited of time, they actually call our crisis line directly right to Catholic Community Services. So they don't have to go call the crisis connections because that's just one more person to call. So they can call our line directly, and then we'll go out to respond, and kind of the same services are offered with that as well. I know a lot of the police and fire have their own crisis team, so we've been getting less calls from them, but we still get calls directly from them. Okay. As a next slide, I think. And this is data. It was funny when I was looking at Claire's data, that trend of the summer months, also go down. These are the crisis program admissions per month throughout the years. You can see on the bottom, this kind of lighter brown, that was during COVID. And then you can see how it spikes up. So that was just to give you an idea. The next one is the referrals of hospitals versus community. Of course, we would always want the light green is the community, always want the community referrals to be the greater number. Once again, unless they need medical attention, we really would like to intervene as soon as possible out in the community. I kind of hesitated whether I wanted to keep this slide in here or not, but we are still seeing some of the impacts of the pandemic, and I think for quite some time we still will. So of course we still are dealing with the workforce shortages. Kids are still having trouble adjusting from remote back to school, and we still have a lot of kids that are still doing work remotely. So that's still coming up as well. There's still a backlog of families waiting for outpatient services. I don't know really any agency that doesn't have a wait list, except for the virtual agencies. We do have still seeing a higher acuity of kids coming in, more severe. And then we're still seeing this too. Youth that historically didn't have any history of mental health. We saw a pretty large increase after or during that pandemic, and now we're still seeing that as well. Caregivers still stressed, and we're just seeing a drastic increase in the overall volume of calls over the past few years. So I think that any questions? One thing that I wanted to add to, something that we do also offer, is if a school or really I think anyone, but particularly we've been involved in the school. If there's a critical incident in the schools, for example, we last year and even this year, unfortunately, there's been youth that died by suicide, and we have been able to go out to the school and triage with the youth there to help support the counselors. I think more recently there was an accident that happened, and there were several schools that had lost children in that accident, and on top of that, one of the schools had lost one of their grief counselors. And so they reached out to us to please come out and help support them as well. So we'll go out and during those incidents and as well and help triage and make referrals if needed. So I feel like I talked a lot and very fast, and hopefully some of that sunk in. But again, feel free to give any, give me a call, email. I'm happy to answer any questions. I'm happy to go out and tell you more about our services as well.
Thank you, Rhoda, so much. There were quite a few really great questions.
Oh, awesome.
I'm gonna pass it on to Stephanie, and then
Mhm.
at the end, all the questions, I'll just read them out and let both of you answer those as we go. So I'm gonna let Stephanie share, and then there were some really great questions from the team. So Stephanie, I will turn it over to you, and then we will move into question and answer.
Thank you, Vanessa. I'm going to try to share my screen. Let me know if this works. Here we go, slideshow. Can y'all see that okay? Or
Yes.
you see it? Okay, cool.
Yeah.
Thanks for having me. My name is Stephanie Gertis. I use she, her pronouns, and I'm the director of our community-based services and programs at the Seneca family of agencies. And I may have met some of you before in previous spaces, but I'm really excited to be here to present on Seneca's new crisis response services in Pierce County. And so I realize we have till 4 o'clock. Is that right, Vanessa? Okay, cool. I will keep this really brief so there is time for questions. But I just wanted to introduce Seneca as an organization to you all a little bit, and then specifically really focus on the new crisis work that we're doing in Pierce County. So for those of you who may not know who Seneca is, we were founded in 1985 in the Bay Area. We began as a residential day treatment program and have since really expanded to provide a broad range of services on a continuum in mental health, education, and juvenile justice for youth in California and in Washington State. Here in Washington State, we provide services in Pierce and King County. And this is just a quick kind of snapshot of some of the broad categories of the work that Seneca does. We do have school-based mental and behavioral health services. We have community-based services, outpatient clinics, juvenile justice focused work. We do a lot of work with foster care and adoption, permanency and family finding in California specifically. We have our own Institute for Advanced Practice that really focuses on training and advocacy. And we additionally have a program that is supporting reunified immigrant families at the border. So that was kind of like agency-wide work that we do at Seneca. In Washington specifically, we really focus on school-based work. We have school specialist services. Those are things like occupational and speech therapy in partner schools. I mentioned outpatient, juvenile justice. We have a CSEC outreach and prevention program. We provide WISE services, therapeutic case management, supervised visitation, and now crisis work. So again, you may have lots of questions about some of the other work that Seneca does, and I'm happy to connect with anybody outside of this space as well. I'll share my emails in the slides, but I'll put it in the chat later too. But we're really, really excited to be coming on board as the second youth crisis responder in Pierce County. And I think as some others have said, there's just a really great need. Youth and families really need additional support in this particular area. And so we're really excited to be able to come on board and provide that additional support. We're really following the same model of service that CCS has. And so we really hope that that's, I guess, maybe one of the key takeaways I would say after today's webinar is for folks to know that there's really no difference between the service you should get from CCS and Seneca. And we want there to be a very clear, like streamlined kind of process for how to access services. So in Pierce County, Seneca is a new crisis responder. And we have two teams, two kind of models of service that together make up what is called the MRSS model of service. And that stands for Mobile Response and Stabilization Services. So Seneca has a mobile response team. That is a team of one clinician and one peer support specialist that will respond to crisis calls received through crisis connections. And then the stabilization part of our work, we are calling START, really similar. It's similar to what CCS calls FAST. So each organization may have a different name, but the service is the same. So START stands for Short-Term Assessment of Resources and Treatment. And again, this is a team of one clinician and one peer support specialist who will provide intensive stabilization services for 8 weeks following this MRSS model of service. So what is MRT? This is our mobile response team. And effective this Sunday, I'm very excited to share out that we have been providing service, but it's been a bit limited, like limited days and hours, while we continue to focus on increasing our staffing and hiring for positions. But this Sunday, January the 28th, starting at 10 a.m., Seneca will be a 24/7 in-person youth crisis response for youth throughout Pierce County. And Pierce County is a large county, but we will go wherever we need to go. And it's regardless of insurance coverage. So it doesn't matter what kind of insurance youth have. If they are calling Crisis Connections and if they want an in-person response, we will go. All calls to Seneca's new MRT program must first go through Crisis Connections. And so this is where I hope that the process is streamlined. And I don't want anyone in Pierce County sort of wondering, like, how do I call Seneca or how do I reach CCS? If it's a true, you're requesting a mobile team to respond to a crisis, you call Crisis Connections first. And so that is hopefully helpful to know that there's one number to call. Crisis Connections will hold how they are making sure they alternate the calls. So if they send one to Seneca, then the next one goes to CCS. And so that's really for them to hold, and they're doing an excellent job so far. Our MRT team always dispatches a team of 2 staff, 1 clinician and 1 peer support. A thorough assessment is conducted over the phone to ensure that safety is, there are like safety considerations are being taken into concern. So if there's any imminent safety risks, like if there's weapons, if there's high aggression, if we deem that it's unsafe to send our staff into a situation, then we would divert that call to the police response for safety reasons. So that would be like a really extreme circumstance. But if someone's, highly aggressive and they've got a weapon, and they're, we're not going to get there for like 20 or 30 minutes anyway. So the police is the safer and faster response. But we haven't had any of those calls yet, so that's fortunate. And our services are focused on immediate crisis de-escalation, the creation of a safety plan for the youth and family that they will use after our MRT team leaves the site. And all of our mobile response team clients, they receive up to 72 hours of follow-up support from Seneca. So we are going to go out and respond to the initial call. We're going to focus on crisis de-escalation, stabilization, creating safety. But then that youth and family is connected to Seneca for 72 hours after that crisis. So that can look like us calling the next day or offering an in-person visit the next day, ongoing safety planning and continued resource linkage. So once the client comes to Seneca for the initial crisis call, they also get access to 72 hours of follow-up. Stabilization. So this makes up our stabilization component of the MRSS model. It's an 8-week stabilization service. And so all youth in the stabilization program must first have a crisis encounter. So the way that happens is maybe the kid has gone into the emergency room or emergency department, or they've called the crisis line, or they've had a mobile team come out to their home. That would be the initial crisis encounter that then would determine, through careful assessment, like, would this particular youth and family benefit from 8 more weeks of continued support? And so the START service provides intensive post-crisis supports for youth and family. Again, it's a team of 2 staff working with a youth and family. And these services can take place in the home, in the school, community. Again, kind of as Rhoda had said, we're going to go anywhere our clients and families need us to be. And the goal of this service is to provide more of that comprehensive support following a crisis situation, so that we're kind of further focusing on the sustainability of the safety and stabilization, and then long-term connections and linkages to additional resources. So how to access the services. Again, for the mobile crisis response, all calls first go through crisis connections. So you call them at that number and they will dispatch to either Seneca or CCS. And then if there's any additional questions, I put my email here, and our assistant director of the crisis programs, who couldn't be here today, but her email is here, Christy Little, as well. So I said I would keep it short and sweet. And those are my slides. So happy to answer any questions, and I'll put my email in the chat.
Thank you so much, Stephanie. Again, welcome. It is so exciting to have done a lot of work, had a lot of conversations, and really seen the needs of the community. We have a few minutes for questions, and this also is being recorded. It will be on the Kids Mental Health Pierce County website as well. And I will also include follow-up emails. It looked like Stephanie provided a couple, and I know Rhoda provided a couple. So we absolutely will share those out as well. I do want to ask a couple of these questions. There were questions that were asked a couple of times, and one was, what if CCS or Seneca don't come, aren't able to come, then who would they contact? How would they follow up? And what would you suggest they do in the event that they are told that a crisis team can't come?
Yeah, I think for us at Seneca, and hopefully this will be aligned with what Rhoda would say, we never decline a call unless it would be for safety, like imminent risk of harm to our staff. So in our phone assessment, if we have determined that there's sort of like, and I'm talking about pretty severe situations, there's a loaded gun and someone's, pointing it at someone, we wouldn't send our team into a situation that's that unsafe. The police would be a faster and safer response. But aside from the assessment that like our staff could be harmed, we would respond to any call.
One question asked specifically if a parent or guardian are not able or available to be there and they were declined for that reason. Rhoda, I don't know if you want to speak to that,
Sure.
or what they could do to follow up.
So we can be pretty creative in that. If a parent is not, we actually had this last night, a parent wasn't able to come to the school, but we were able to collaborate with them over the phone, and then reach out to other resources to get the youth back home safely. So we can be creative. Sometimes there's family members, sometimes there's friends that we can reach out to. We seldom decline just because there's not a parent available. Usually there's some responsible adult that we can safety plan. Again, we've safety planned with youth that are homeless. And so it's just about being creative.
Thank you. This is a little bit of follow-up to that, but since youth can consent to their own mental health treatment at 13, why does a parent or caregiver have to be present or notified of crisis services?
That's a good question. And because it is a crisis services, that's where legally I think this is true for adults and or children, we are legally obligated to reach out to a care provider or another responsible adult when another person is in a crisis situation.
I think probably what Rhoda's hinting at is like, it's important to distinguish like, and I think we're all familiar with the boundaries of confidentiality, right? So like if there's really an imminent risk of harm to self or others, that's when we have to break that confidentiality and notify a caregiver or a parent, an adult that can keep the child safe as well. And then there's some assessment around, maybe there's a crisis call. Like we've gone out on crisis calls at Seneca, but there wasn't a need to inform the parents or caregivers because there was no imminent risk of harm to self or others. So, it sort of depends. I'm guessing it depends on the severity of the situation. If you are really needing to safety plan, you've got a kid who's, got a plan and actively suicidal, we have to notify, we'd have to break that confidentiality and notify a parent. But sometimes the calls are not that severe. And so I don't know if it changes things for you all at CCS as well, Rhoda, if it's, not imminent risk of harm to someone.
Yeah, I did add in the comments, like from my previous hat as well as emergency department, that this is something that all therapists, social workers, psychologists, that if they assess that we let young folks know around consent and what we do have to share. And that is one of those components. So when we're contacting families from an emergency department or from a school, from a community, that for safety support, that those assessment and those needs will be evaluated, and that is what will be shared. So I believe that's true for all of us around safety. There are so many great questions, and I am going to ask one more, and then I think that we will plan a follow-up webinar conversation. So look for that in your email, and that to be planned with Stephanie, Rhoda, Catholic Community Services, Seneca Family of Agencies, and Caroline, our crisis contract holder. We can answer questions around crisis connections, which is the number you called. That's who will answer your calls. I had that question in there, but there was one more question I wanted to ask around what is the best number to call if someone is trying to elope from school or kind of aggressive or trying to elope from school or the home. What would you recommend calling?
I think I'd still say call Crisis Connections, and they do a great job of assessing. I think they know our time frames as well, which is like depending on where the youth is and where we are. Sometimes we can get to a situation in 20 to 30 minutes, but maybe it's longer if it's further away. But if there's a really imminent risk of harm, I think you still got to always consider calling 911 if they're going to get there faster than our mobile team would if there's a real imminent safety risk.
Thank you, Stephanie. There also is a new youth crisis collaborative meeting developing that will be starting in February, a co-facilitated meeting between Carillon and Catholic Communities and Kids Mental Health Pierce County that will have Catholic Community Services and Seneca Family of Agencies available to answer questions, to learn more about some of these questions. We could bring some of these questions directly to those meetings through our partnership to answer directly, to share information, to provide resources. So I'm very, very excited about those youth crisis collaborative meetings that will be meeting on. The first one will be February 15th. They will be the third Thursday from 11 to 12. And those will be great places that we can continue conversations, ask questions, clarify information, and remain connected in supporting our crisis services for youth here in Pierce County. Again, there are so many questions, and I think this is a great place to continue that conversation. I will share out the invitation, forward out the invitation for this meeting with all the folks that have attended. This webinar will be recorded and put on Kids Mental Health Pierce County website. Again, I will share out emails and information, and I want to continue to be connected and collaborative with everyone in attendance and with all of our crisis agencies to better support kids and families here as close to home as possible in Pierce County. So again, thank you so much, Claire, who dropped off, Stephanie and Rhoda, for your support, for your passion, for all that you do here, and everyone who was here today. Thank you for attending. Share out the meeting, share out the information, and we can continue to just keep growing and supporting young folks here in Pierce County. Again, thank you all, and looking forward to seeing you soon.
Thanks, Vanessa. Thanks, everyone.